Let me start by first thanking my colleagues and esteemed leaders of the conference for inviting me here to speak with you, and for acknowledging the hard work that all of you do for your patients and for the systems that treat your patients. I am so inspired by all of you and by this organization, and I have to tell you the honor is truly mine to be here with you today. So you're at a very exciting point in your journey as you start your EHR implementation journey. And I'm here to talk to you about the power of your EHR data. So I like to think of the electronic health record as just a building block, as a foundational element that you springboard off of. And I'm going to talk to you about our context, or my context at Humber River Health, and what we've done with our data. And you know, the governor presented me with a challenge, and I love challenge. It's in challenge that we grow and learn. When he talked about some of the gaps, and it's important to recognize those. But I hope that we can also show you examples of things that can be done so that you understand what the potential is. So with that, let me start with some context of where I practice. So Humber River Health was initially a 3-site hospital, or 3 large campuses. And our catchment area, so we're a busy center, we had aging infrastructure and increasing population density. So we had some real problems ahead of us. Our population, I'm going to say, has a lot in common with the populations that you serve. So when we compare ourselves with neighboring catchment areas or catchment areas in our province, Humber River Health has the first highest number of unemployed individuals in our catchment area, as well as those without a certificate, diploma, or degree. We also have the first highest number of, of lone parent families, so what we call single parent families. The second highest number of racialized populations, and the second highest persons that would fit into a category that we would call low income. So all of this tells you that there is a larger resource demand on our health system, because you know enough to know that this tells you something about the health of the populations that we serve. We wanted to solve certain problems as an organization within the 4 walls of our hospital. We had patients waiting in our emergency department for admission for almost 24 hours in stretchers in hallways. We had often medicine beds at 99% capacity, and we just couldn't manage our volumes. And our resource levels were not dynamically adjusting to the demands. And I use that word, it's knowing what's happening allows you to make those adjustments, right? And that's really important. And we had little to no real-time awareness of what was happening when it came to our patients that was contributing to delays in care or missed opportunities in care. But we wanted to be even bolder than solving the problems within the 4 walls of our hospital. We wanted to look at systems problems as well. So we know that in Canada, 1 in 11 patients is readmitted to hospital within 1 month of discharge. And that's a huge cost to the system. But more so, we know that that number is actually 20% higher for patients that come from the poorest catchment areas. Those are our catchment areas, right? We also wanted to address hospital-related harms. We know that in Canada, 1 in every 18 person admitted to hospital is going to experience some form of harm. We wanted our patients to come to a hospital that was safe and reliable, so that they weren't coming to a hospital where they knew that there was a high likelihood that there would actually be mismanagement in their care. So we started our digital transformation in 2005. Fast forward, this is Humber River Hospital today. We amalgamated our 3 campuses together, and we are now, this was our title, North America's first fully digital hospital. So a little bit of context for size. We're about a 750-bed hospital. We do about 450,000 ambulatory clinic visits per year. We have a large oncology platform, mother-child platform, renal dialysis platform, etc. We do about 40,000 inpatient and 30,000 outpatient surgeries per year. And we have a very busy emergency medicine platform, and that's my home as an ER physician. We do about 140,000 ER visits per year. When we embarked on our digital transformation, we had 4 major components of that transformation. The first was about being digital, getting our information off paper and moving to digital processes. The second was about being like an entire mobile connected strategy. And so this was around supporting mobile workflow so that you had the information you needed in the right context and could act on it in your workflow. The third was a patient empowerment strategy. And the fourth was about systems automation. And in that picture, you're seeing one of the automated guided vehicles that moves around the hospital, delivering linens and with locked cabinets delivering medications. For this presentation today, we're going to focus on the first quadrant, on the digital information piece. I'm going to talk to you about three things. So we're going to talk about data driving care, and I'm going to start with the command center concept. And this is a concept where we're going to look at how you can use your data to get a view of your system. That system might be one hospital. It might be multiple hospitals that are geographically quite far away from each other, but considered one network of hospitals. So how we use that data at a systems level. Then we're going to zoom in a little bit, and we're going to talk about self-service analytics and how we can use data analytics at, say, the department level or at the groups of patient level. Then we're going to zoom in, finally, to the clinician sitting right in front of the patient, and we're going to talk, and I'm going to give you an example about natural language processing, a type of artificial intelligence that we're using to support clinician workflow. So let's start with command centers. So when we look at all of the data that we had, and I've boxed some of them for you there, we think most of this data that feeds our command center is coming out of our electronic health record. We are a Meditech site, as are you, okay? So when we look at the data, this is data like registration data, payer data, labs, genomics, which is becoming an increasing source of data, right? Pharmaceutical data, medical imaging data, and then of course health records data or information from health records exchange. So what we did was we looked at feeding this data into a command center. We partnered with GE. And what we did was layer the GE prediction logic engine over that data that we had to create a system where we were leveraging predictive analytics and machine learning, as well as a lot of human input. Our clinicians were very involved in the algorithms that we built. Every stakeholder in the hospital, whether it was a porter when we were looking at improving our portering benchmarks, a cleaner, a nurse, a dietitian, a physician, you name it, were involved in helping us develop the right algorithms. And we put all this through the engine to get to where we are today. So instead of me doing so much talking, I'm going to show you a quick video about our command center.
The command center is the really cool piece because it takes all the data that you have and does something with it. It amplifies it from the point of view of driving efficiency, creating capacity, improving quality. And that has been proven out, not just at Humber, but at Hopkins and all the other GE Command Center ecosystem members. And now you see the whole world is talking about command centers, and for very good reason. These things deliver.
The 35-bed savings results was noted after the first year. So we presented a business case to our board of directors, and we thought it would take us 2.5 years to get there. It took us about 11 months to save the 35 beds. So we set efficiency targets for turnaround of a dirty bed, for portering, for diagnostic imaging procedures, length of stay for patients waiting to go to a long-term care home, and of course, the amount of time it takes to get a patient admitted from a merge to a bed. And all of those have decreased by at least 30%, and some of them as much as 50%. The true savings is in patient harm. But there is also a savings in the societal costs because they are not well, and those are the true costs that we are working to quantify now. And that's really what we're here for in healthcare. I worry about the money every day, we all do, but I really worry about the care to our patients.
We've seen a 10% decline in our sepsis-reported morbidity and mortality at Humber River Hospital.
We have virtually zero medication errors. In the country, across Canada, it's 2 to 5% of the medications administered might be at the wrong time to the wrong person or the wrong drug. And at Humber River Hospital, we are at 0.03%. We do make our data available. We'll show anybody anything. We'll share anything. Because I really feel that in healthcare, particularly in a system like we have in Ontario, where it is provincially funded, those are provincial dollars. And we should all have a mission and a belief that we are helping each other to become better hospitals. Humber River has learned a lot from other hospitals. We have something to offer in the command center to our colleagues in Ontario, and we never mind sharing that.
When we established our command center, we wanted to do it in 3 stages or phases. The first, we call them generations. So generation 1 was about access and flow. This was really driving operational efficiency in the organization. The second was our high reliability phase. This is where we focused on clinical pathways, reducing what we call never events, the things you don't want to have happen. And then the third generation, which is what we're in now, is really about care transformation, leveraging the command center as a backstop to not just monitor patients in the hospital, but to start moving into the world of remote care monitoring and saying, how do we actually leverage this to monitor patients outside of the hospital? So really scaling what we're doing. This is an example of a command center tile, just to give you a sense of what it looks like. This is the emergency department status tile, so this would have been part of generation 1. This is on operational flow. And I show you this because I want you to understand this is not a dashboard. So we're not just looking at, how many numbers of patients are sitting. It's not census. There's intelligence overlaying, so we have things like pressure scores, which you see at the very top there, saying based on everything that's happening, you are moving into a pressure score that is red. You see these little alarm signals. That's telling you that things like length of stay for a certain kind of acuity scale has surpassed a threshold. But this isn't just for somebody that's sitting upstairs in the command center facing what we call the wall of analytics, these screens acting upon it. There are things then that automatically drive changes in workflow at the front line. Nurses, physicians, people are getting indication within the electronic health record that they need to do something differently. Or from the command center space, we are sending resources down to that department now because we recognize that they're at a higher pressure. Or we're working upstairs and saying, guys, we need to clear more beds because we can already see what's coming. There's going to be more admissions and we need to have capacity for those admissions, right? These are some examples of the tiles that we use for generation 2 that look at clinical outcomes. So you see a perinatal tile where we're measuring neonatal early warning scores, obstetrical risk, and in the bottom just below that is a deterioration tile where we look at clinical deterioration. So we're using early warning score similar to the NEWS2 score for those who are familiar with it. We customize it, but what it'll do is drive right into the nursing workflow a change in the frequency of things like vital signs. It will drive a change to the physician workflow to say maybe you want to go ahead and order a blood gas on this patient. Things look like they are deteriorating. So it's looking at the delta also of these scores over time to measure risk of deterioration. So when we look at the outcomes of our command center, some of them you heard in the video, but the first one that our CEO talked about was the 35 bed savings. So I just want to be clear on what that means. Our target was within the first 2.5 years, we would hopefully be able to add 35 bed capacity to our hospital without a single injection of human resource or money, without a single dollar going to serve these beds. We achieved that metric in 11 months after starting the command center. That's huge when you think about what it costs to service a hospital bed, right? We also decreased our reduction in acute conservative medicine bed days by 52%. That's important because for us in our public funding model, when a patient stays in a hospital longer than is typical or that is being funded for the condition that they have, that creates the cost that the hospital has to now figure out how to pay for. So we were able to actually create leaner processes that we decreased that metric by 52%. And then there was clinical outcome metrics. So after establishing our deterioration tile, from 2019 to 2021 was the measurement period, we had a 41% reduction in inpatient code blues. A 41% reduction in inpatient code blues, because we could see things coming before they happened. So we could say this patient needs to be rounded by the critical care response team, put them on the CCRT list, because things look like they're going south, before they went south. And so we were able to prevent these poor outcomes and reductions in medical imaging times and things like that. So we talked about command centers very, very quickly. Like that command center presentation is usually like a 1-hour presentation. So I'm taking you very fast through the journey. But now we're going to zoom in a little bit and we're going to talk about a concept called self-service analytics. This is not new in other industries, but is fairly new, I would say, in healthcare. This is where you are giving the person who is line of business, front line, access to data to drive decision making. They know their business well. Your physicians, your nurses, your clinicians know their business well. You want to empower them to be able to ask questions of data, not to have to depend on somebody in a back office on IT to run a report for them. You want them to be able to filter through that data in different ways to figure out what's happening in my department. As an ER doc, I want to know, the asthma patients that I discharge home, how many of them are coming back? And what am I doing differently than the other doctor if my rates are different than that doctor, right? You want to be able to benchmark against yourself and against people in your own department, not just a benchmark that's external to your organization. I'm going to show you a very quick video by Warren Ratcliffe, who is the CEO of a company called Adaptix. And I have no relationship with this company. I just think this is a nice video to illustrate what self-service analytics can do. He was at an AWS conference. So he's going to talk to you about a use case in surgical workflow.
Efficiency. Again, we've all digitized our hospitals. So here you're looking at an OR. I don't know if people have spent time in an OR, but you can see all these different stations where you've got 4 different people in.
And they were able to bring it down so much. You can just see that curve. I don't need to give you a number to see what the improvements were. These types of tools support quality improvement and research because they support this idea that you can make iterative changes, implementing PDSA cycles, you name whatever the tool is that you're using, but for continuous improvement because you're getting that real-time feedback. Similarly, Seattle Children's looked at their emissions for inhaled anesthetics, and they were able to bring down the rates of the emissions as well. So, rapid fire. Now we're going to zoom in one more layer, and we're going to go right down to the clinician sitting in front of the patient. And I'm going to talk to you about natural language processing. So this is actually taken right off your website. I want to give you an example from multiple sclerosis. So multiple sclerosis is a disorder, for those that don't know, that it's an autoimmune disease that affects the central nervous system. It affects the brain, the spinal cord, and the optic nerves. This type of, what you have when you have multiple sclerosis is patterns in illness, and we call them sometimes relapsing, remitting, but people get better, get worse, get better, get worse, and individuals have different patterns. Some people continuously deteriorate. So knowing your patient's patterns can really help drive the care for that patient. These patients also, this is a chronic illness, right? It's a long-term debilitating illness. So you can have a patient that's had MS for 10 years. If you're new to the clinic and you want to understand your patient, that specific patient's history, you have to go through 10 years worth of data to do that. And the electronic health record is not going to do a good job of summarizing 10 years worth of data for you as it stands on its own. Unity Health, a large academic hospital, much like yours, but based in Toronto, developed a tool that they call Muskrat. They applied natural language processing to the electronic health data, and their tool summarizes 7 years of data in 2 seconds with over 90% accuracy. I'm going to say that again. Their tool summarizes 7 years of data in 2 seconds with over 90% accuracy. So the clinician sits down and gets to look at a snapshot to understand what this patient's particular pattern is, so that when they're planning future appointments and interventions, they can do it in a way that matches the pattern of this patient.